Hello, I'm Andrea Denafe, and we're here at Endocrine 2019 in New Orleans. And I've just finished speaking about what every endocrinologist really needs to know about polycystic ovary syndrome, or PCOS. There's been a lot of confusion amongst endocrinologists about which are the appropriate diagnostic criteria. There have been recent publications that patients need to see on average of 4 endocrinologists before the diagnosis is made, and they're very unhappy with their experience being evaluated for PCOS. So what I talked about is the essential endocrine workup to diagnose patients with the endocrine features of PCOS, that is, symptoms of androgen excess, or the metabolic features of PCOS, such as diabetes, prediabetes, metabolic syndrome, and what are the testing that they really need to do. And I put it in the context of some very exciting recent genetic data that showed that when you compare the different forms of PCOS diagnosed by the different diagnostic criteria, there's no genetic difference. So we really don't need to sweat the diagnosis. We can use very broad criteria and make an accurate diagnosis and manage these patients. And I think the major take-home message for endocrinologists is that we don't need to assess the ovarian morphology. We need to check testosterone levels, both total and free, or better yet, what's not bound to sex hormone binding globulin. And that can be easily done by measuring the total testosterone by liquid chromatography tandem mass spec, and measuring the sex hormone binding globulin. And then there's a calculation that can give us the amount that's not bound. And we can order that from the laboratory, so it's documented in the chart. That, combined with a history of irregular menstrual cycles and excluding other what are really uncommon disorders in the differential diagnosis, such as hypothyroidism or high prolactin, that very limited workup will give us the diagnosis of PCOS. And if the patient is overweight, we also want to do a metabolic workup and exclude diabetes with a 2-hour glucose tolerance test with a fasting and 2-hour glucose, because a glycohemoglobin isn't sensitive enough in PCOS because they have mainly postprandial hyperglycemia. We want to check a lipid profile because metabolic syndrome is very common in women with PCOS, as are minor elevations in LDL levels. We're then left with patients who usually have 2 distinct therapeutic goals. They're either concerned about weight management and their metabolic issues, prediabetes, or another group of patients is concerned about their symptoms of male hormone excess, their androgenic symptoms such as hirsutism and hair loss. For the patients who are concerned about their metabolic symptoms, weight reduction is very effective. Metformin is also effective at restoring regular cycles. We usually give a 6-month trial to see if the patients will respond to metformin. For women concerned about their symptoms of hirsutism or hair loss, the key therapies are combined oral contraceptives with an anti-androgen. And in the United States, the anti-androgen of choice is spironolactone. We usually give it in 200 milligrams daily. That's 100 milligrams in 2 divided doses. And so with this straightforward workup and minimal metabolic testing, if indicated in an obese woman or a woman with strong family history of type 2 diabetes, we can precisely define PCOS, we can manage it, and we don't need to be obtaining ovarian ultrasounds in everyone. And in fact, the most current international guidelines on PCOS that have been disseminated worldwide say that if the patients filled the 2 main NIH criteria for PCOS, hyperandrogenism and irregular menses, they don't need an ovarian ultrasound. And the Endocrine Society guidelines for the management of hirsutism say that ovarian imaging is not necessary if it's just a management of androgenic symptoms. So I think we can be very simple in our evaluation and much better serve our patients with an effective diagnosis and management plan.